Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goey. I'm the pro-rector and the chair of the ceremony and the chair of this degree committee. First of all, I would like to welcome Mrs. Erin Barry, and she will defend her thesis in public. And the thesis is called Leadership and Followership Within Healthcare Teams, Exploring the Roles and Collaborative Dynamics in Interprofessional Teams. Welcome all members of the degree committee. They are not all here present in this aula, but also present online, as you can see on that screen. And I will introduce now first the two supervisors, and I will introduce the 5 opponents later during the ceremony. So welcome the 2 supervisors, Professor Pim Teunissen. He is Professor of Work-Based Learning in Healthcare at Maastricht University, and Professor Lara Varpio. She is professor and she is present online, and you have to look at that screen to see her. She is professor at the Department of Emergency Pediatric Medicine at the Children's Hospital of Philadelphia and the University of Pennsylvania in the USA. Welcome to you all here in the aula, and I would like also to welcome the followers of the live stream. Mrs. Barry, may I invite you to present a summary of your thesis, and I wish you a lot of success in the coming hour. The floor is yours.
Thank you. Thank you to Pro-Rector, members of the committee, my advisors, and family members and friends. I'm very excited to talk to you about my work today. My interest in leadership and followership started with my dad's cancer treatment. And over the course of his treatment, there were many great experiences he had and many not so great experiences. And one specific bad experience stood out and really made me start thinking about this topic. And while he was in the hospital, he had had some complications, went in, and had multiple different physicians and their teams show up and provide multiple different diagnoses, multiple different next steps, and multiple different answers as to when he would get to go home. So this left both him and my mom very confused and very distrusting of the system as to what they should do next. And the problem was that each of those physician teams was leading. There was no communication between the teams, and everyone was in charge. So the AAMC states that leadership development has never been more essential to anticipating, navigating, and solving the complex challenges facing today's medical schools and teaching hospitals. And so as educators, how do we develop our learners to work in these interprofessional teams? We know through some research that effective collaboration reduces medical errors and improves patient outcomes. And much of the literature out there is focused on how do we prepare healthcare providers to be leaders. And leadership development is what the focus has been through most of the research done to date. So while leadership has received a lot of attention in training as well as practice, followership is often underappreciated. And the traditional way of thinking about followership is that it's very passive, very dependent, very submissive. If you even look in the dictionary, the definition of follower is one in service to another, one that follows the opinions or teachings of another, and one that imitates another. So there's not much active happening in these definitions. But over time, followership has started to receive much more attention in education as well as in the research. Recently, followership was redefined as the leadership practice by individuals in positions of responsibility but not authority, where they're able to exert their influence to be able to achieve the goals of the team or project they're working on. So this led us to think about the big question for the dissertation: what are leader and follower collaborative dynamics in interprofessional healthcare teams? And we looked at this through a constructivist point of view, so thinking that all of these teams are very socially constructed, and so we wanted to understand from different points of view how they are defining leadership and followership. 5 studies were conducted. We're going to go through the major findings for each of these, but kind of giving you a layout of where we are. So the first, we wanted to really look at what is happening within followership, and we wanted to look at how it's changed over time. And we were unable to find a methodology that would provide this for us, and so we worked on creating a state-of-the-art literature review methodology. We then conducted that state-of-the-art review, and then we wanted to look at what was happening in the different contexts. And so we looked at the attending physicians in different contexts, as well as military interprofessional healthcare teams. And finally, we looked at how do we prepare our teams to function effectively together. So the first study was, again, that methodology. The word state-of-the-art is used very often within the literature, and we were wondering how they were performing all of these different studies. We reviewed 900 papers and found that very few of them actually stated a methodology, and the only methodology we had was 2 sentences in a review paper on multiple different methodologies. Since September 22, when this paper was published, as well as 2 related ones, those have been cited over 120 times already, showing that multiple people are looking for a methodology to use when writing a state-of-the-art review. What we found in this review is that the purpose of it is to show how we got here, where we are now, and where we're going to go next. So that then led us to the second study, conducting that state-of-the-art review on what historical developments led to current conceptualizations of followership in interprofessional healthcare teams. So we got here, the word followership showed up first in 1993, and through 2011, it was very leader-centric. It was focused on the leader telling the followers what to do. But that started being challenged by people within the business literature, within healthcare teams, within interprofessional education as well. So where we are now is that followers are active members of the team. We expect them to be involved in the process. And that traditional views still exist for followership. So where we're going next, the literature and the theory are really pushing that we should have active followers on teams within shared leadership. But what does that mean within different contexts? So moving to the different contexts, we wanted to look at within clinical settings, how are leadership and followership dynamics conceptualized and realized in clinical interprofessional healthcare teams by attending physicians. We chose to look at, again, the attendings because they are defined as the leaders of the team, and focus on the perioperative environment, so the pre-op, operating room, and post-op, as well as the emergency room department. What we found was that our attending physicians were very comfortable sharing intra-professionally, so within their profession with other physicians, especially in that educational setting. But they had very hard times coming up with stories and ways that they were sharing leadership interprofessionally, so with the nurses, with the techs. And we also found that they really appreciated active followers, so people stepping up and saying when things weren't working or if they had another idea, but it was when appropriate. And that when appropriate happened, and it was very subjective. And so they were not very clear as to when everyone should be active or be the passive follower that they wanted. So from there, we wanted to look at military interprofessional healthcare teams and look at what are the qualities that are supporting these teams in their collaboration. And what we found there is that there was a foundational theme that really came out and that had to be there for us to be an effective team. And they were collaborating to fulfill a common mission. And without that mission, nothing was going to be as effective. There were going to be things that would come up and make them ineffective teams. And from there, they had to have an understanding of their own role as well as the roles of others, mutual respect and recognition for every member of the team, to include the leaders and the followers. They had to be flexible to be able to adapt to the different contexts that they were working within, the different patients, different times of day, different resources that they had available. And they also had to have psychological safety within the team so that they were able to stand up and say when something wasn't going right, or if someone else had a different idea, or any member of the team was able to train other members of the team. And with that, they were able to share those leader and follower roles much more fluidly. They were able to pass that off depending on whose expertise was needed at that time. So the final study looked at when we have these teams, they usually have to function very quickly together. Sometimes they come together quickly and have to perform as a team right away. So how can we look at how do we train them to look at those things very quickly so that they will function effectively on a drop of a dime? So the first finding we found was that they had to be very aware of their own readiness. It required that self-awareness so that they were clinically ready, emotionally ready, physically ready, and spiritually ready. And when they had that, they were then able to contribute to the team. They knew their limits as well as their strengths. They also discussed that unique adaptive communication. And so there's a lot of overlap that they had to understand that mission and the context that they're going to work within. Because if they don't understand those, they might not have clarity around their roles and what needs to be happening. So again, understanding the roles of all members of the team was very important, and they knew they had to adapt. So you cannot be in a fixed mindset when working in these different situations that they work within. And finally, training was ongoing. It was something that was it was not limited to the setting that they're working within. It was not limited to just yourself. All members of the team needed to be involved in interprofessional training with each other before they were deployed, when deployed, and even coming back home to fill the gaps that they were needing to fill. So where are we going next? This brought up a few big questions that we wanted to start thinking about. And that's, should leadership and followership be taught together? We know that these are very interconnected themes and theories, and there's a need for that fluid transition in the different roles. We do know that leadership is often emphasized, whereas followership is often overlooked in many settings, and even within educational programs. So we should be teaching these as complementary skills and finding ways to insert followership into different curriculums. The second big question that came up is, what are the implications for patient care ownership? So again, not having that all the different teams coming to it and having their own mind, but how do we work together and remove that individual ownership to more of a shared accountability for everyone on that team? Because that's going to lead to enhanced decision-making, distributed accountability, as well as being able to have more holistic patient care. We're going to know more about the patient when we're communicating with each other. And then it allows us to have that shared mission alignment. We know what we're working towards. And the final question we asked was, how do we approach the hierarchy within medicine? Because we know it exists, and so how do we work with it? Because it's not going to go away. Because the hierarchy is going to provide structure, but it might stifle some of the innovation that happens. The barriers to having hierarchy is that it discourages people from being active members of the team, and it could hinder that open communication that is needed to have the answers that we might need to help the patient. But it also provides some clarity and is a facilitator. It can provide clarity of what's needed, of who's in charge of the team, and can provide accountability of what's needed for each member of the team, and everyone knows what's needed. So we need to find ways to promote training in communication, emotional intelligence, conflict management, to be able to build that psychological safety in that team environment, in a space where there is hierarchy. So as we thought about those three big questions, it led us to an even bigger question. And are these research, education, and/or cultural problems? And as I bring it back to the question I asked originally, is as educators, how are we going to develop our learners to work in these interprofessional teams? So with that, I'd like to thank my advisors, my family, friends, and colleagues that have joined. And Pro-Rector, I turn it back to you.
Thank you very much for your clear summary of your thesis. And we will start with the opposition now. The first opponent is the chair of the assessment committee, Professor Erik Driessen. He is professor of medical education, in particular learning and assessment in the workplace. And he is affiliated with Maastricht University. Professor Driessen.
Thank you, dear Pro-Rector. Dear candidate, congratulations with this fantastic work. It is well written. You have published all your studies in important journals, I think. You made me think. That doesn't always happen when I read a book, but your book made me think. I had never systematically explored the phenomenon of followership, neither the state of the art as a methodology. I had taken that for granted, to be honest. So congratulations for you and for your team for this marvelous job. But my role is to question your work, so I'll do that. And I see you brought a team with you, so I want to make it a team effort. And my first question is about Proposition 6. Maybe one of your team members can read that proposition.
Shared patient care ownership enhances the quality and efficiency of healthcare delivery.
Okay. What often works well to question a statement or a proposition to change a word by another word. If I change patient care with dishwashing, it becomes shared dishwashing ownership enhances the quality and efficiency of dishwashing. Now, I don't know who are team members in the audience, but maybe some are. I have a team of 4 at my house, and if I include my wife and myself, we have a team of 6, and a dog, but we don't want him to join the team. I try to communicate that the dishwasher is a shared team responsibility, but that doesn't seem to work the past 26 years. So now I have a specialist here, so I want your advice. My experience is if I say to one of my family members, today you are responsible for filling and clean and emptying the dishwasher, that works much better than I tell them, team, it's a shared family responsibility, nothing happens. If I translate that to healthcare teams, it makes clear that there is a tension in shared responsibility and not taking responsibility. Sometimes it works better to give one individual the main responsibilities. So if you would reflect on your results on the tension in shared team responsibilities and making one individual the most responsible, could you do that?
Thank you.
And maybe you have a tip for how to rule my team. Yes.
I'm still working on that part as well. I think it's a wonderful question because I think it reminds me of NASA. They always talked about, in the beginning when NASA had started, even the janitor said he was sending a man to the moon. So to me, it all comes down to that shared ownership of what is the mission that we're working towards, whether it's patient care, whether it's we need to have a clean house. And so I think as the leader on the team, the leader does have the responsibility, I think, to make sure that the members of the team know what are we working towards? Why is this important? Because I think the why is important, especially with our younger members of the team, to make sure that they understand why do we need it to be. It's not just because the leader's telling you. I think if we can understand the mission, understand the why, that may help us get to that more shared accountability that's happening.
Mission seems to be key in your answer, the shared aim. Now, I don't feel that all the members in my team always have the same aim, and I think, like in study 6, all your participants meant it's even called a mission. There's a shared aim. But there are many situations, I'm not a military, so I only know military from Hollywood. So even there, it becomes interesting when there's not a clear mission. Like, for example, a movie like Saving Private Ryan. Even in the title is it a relevant mission or not? Have you seen the movie? Mm-hmm. Okay. Then you know, why save one person and maybe 10 are killed to save that one person. So I think in reality, the aim or the mission is not that clear or felt as important or relevant, especially in large hospitals or large patient care settings. So in these situations where the aim is less clear, how can we still organize and support efficient interprofessional teams, collaborations? Could you reflect on that?
I would think that if we also have to think about how, as a leader, can we tie the mission to our followers, making sure that they understand for themselves, how do they fit into this mission? Because I think a lot of times as a leader, we see ourselves in the mission, but maybe we don't always. And so understanding from above us, how can we take what is important, what are we working towards? And we know this might be our end state, and I can help you along the way, but how would you get there? And let them decide. It reminds me of coaching and a lot of, how do we get them to understand why they want to be here? And if they don't want to be here, that's could be part of the issue. But trying to get them to understand the why behind why is it important to them? I feel like that's a lot of where our teaching within medical school. Why is emotional intelligence important? Why do we have to talk about communication? And getting people to understand the why behind the mission, behind the goal, behind what we're working towards can help us get everyone on that same page. The military does make it a little easier in that it's sometimes life and death. And so this is what we're working towards. But there's a lot of debate that can happen on the backside before that decision's made of understanding we are going into, this is going to be our mission, and understanding the context. Are we working at the impact of patient injury, or are we going to be working in a major hospital? Because those are going to be different mission sets, and the way we work is going to be different. So I think really, truly, fully understanding the why behind what we're doing can help.
Okay. And makes it a difference, like for example, if I go back to study 6, you describe that the people within a team who are sent on a mission, maybe to Iraq or whatever country or place, they don't know each other often. That's often the same in hospitals or in airplanes with the flight attendants, they don't know. Then what would be your advice to discuss this why and to prepare them for this interprofessional team collaboration in those situations, and then especially for healthcare?
So I think we have to really focus on that immediate part. You yourself have to be prepared to come to that team. And then there has to be that discussion. There has to be that communication with the team to briefly, whose role is what on the team? Can we define who's going to do what? To be able to then, now we kind of know there's a distribution, who's in charge, you get that hierarchy that comes in, but now we know who each person is. We can ask questions then and there. You can ask questions throughout things. But I think getting people to start building that relationship, because I think it's hard to come in and be told immediately, this is what you're going to do right now, without the bigger picture of why this is the people we're working with. So having that communication of who's on the team could help.
Okay, so start with a bit of time to discuss that before you start your shift. Okay, I think my time is over, so we're going further with this team collaboration. Thanks a lot for your answers.
Thank you, Professor Driessen. The next opponent is Professor Lauren Maggio. She is Professor of Medicine at the University of Illinois in Chicago, USA. Professor Maggio, she is present online. And we'll see her on that screen as well.
Dear candidate, thank you for the opportunity to read your work. And I also want to extend my congratulations to you and your team. Like Professor Driessen, I was also intrigued by your use of the state-of-the-art review. You discussed that you conducted it because you were interested in understanding the concept of leadership, which evolves over time. I'm interested, how do you think this specific methodology, out of many review methodologies, provided you the opportunity to think about your specific topic? And then in what ways do you think it improved your understanding of the topic?
Thank you. I appreciate that question. I think it's a very interesting question because we debated a lot between the different methodologies. And we picked the state of the art because as we looked through the table in one of the articles, the other ones weren't fitting. A systematic review, we didn't have a question that needed an exact answer because it's leadership. There's not leadership, followership. It's very subjective as to how people feel and their definitions of what that means to them. So it wasn't going to be similar to a dosage that's needed for a specific disease. So we had to really think about, it's not systematic review. A scoping review we were debating between to try to think about what is the scope and put that frame on to figure out what's happening in that. But we noticed that in the literature, things had changed over time. And so we were trying to figure out how we could show what was causing those different changes. And the state-of-the-art review allowed us to find what are those turning points that were really causing change to happen. And so I think the impact within the field is that it's very much, it had been such a passive field. The term follower is very passive. It's very much, and especially in the literature early on, a lot of it came from the nursing field, and it was talked about in a very passive manner, or from surgery, and that they just wanted people to do what was told to them. And so I think you started seeing a shift, though, of that active followership really coming into play. And wanted to know kind of why is that? And I think the biggest thing was that the business literature really started pushing this active followership. 3 of the scholars started coming up with their own models of followership. And then at the same time, a lot of the healthcare information really started to change as well. When we look at interprofessional education, they were really forcing people to talk about what was happening within that team, and it's not just about the leader. The leader might sign off on all the orders and everything for the patient, but there are more members of the team that are going to help us achieve that goal. And so I think the impact is that it will really help within the team understand why followership has changed over time and how we're going to keep that changing, or if we're going to stay with those active followers but still have those traditional ideas of what followership means. And I think the article itself really helped people have a methodology, because I think most of the articles that we looked at had no methodology. So it was unclear where they were even, what they were searching to tell us that this is the state of the art for this disorder or for this idea and concept. So it gives you something to really consider as you're doing a state-of-the-art review of what's causing us to have this differing opinion and what's changing over time.
So in your review to design the methodology, you did an inventory of other reviews that, as you said, maybe in some cases didn't have a methodology, or they were a bit hand-wavy in how they did their methodology. I'm curious, what are some of the limitations that you saw when you were looking at that inventory in terms of what people were able to do with this methodology? And then did you see any of those similar limitations in your own work when you conducted your review?
Great questions. I think there were limitations because most of the articles did not have a methodology. They just said that it was a state of the art, and that term never came up throughout the rest of the article. It was only in the title of the article. And so you see that happening in most of the articles. The other smaller chunk of the articles had information, and it would be a systematic or a scoping review that they were calling state of the art. And so it is now starting to muddy the water of what do we actually mean by that. And the ones that had a methodology listed, they were a bit all over the place. So trying to use that information and come up with what do we want this to really mean. And reading through some of the other articles, they were trying to show that, over time, we're seeing a change over time of different things, but putting a methodology to it will really help. I think within our own work, the term followership is fairly new to interprofessional healthcare teams, and our scope was limited to interprofessional healthcare teams. We didn't broaden it out to look at a wider scope of followership in the field. So there could be more that could be picked up in those different settings. I think also the field is going to continue to evolve. I think followership is a term that not everyone is comfortable using yet. There's debate within the field of whether they should change the name to something different. But the big scholars debate that it should stay followers because that's what the term is, and that we should be more active. So I think other limitations it's an evolving field. And so what we've written is going to continually evolve as well, I believe.
Great, thank you. I want to shift gears just a little bit. In each of your studies, including your review, which I was very impressed by, you included a detailed reflexivity section. So related to this, I wanted to know more about how you designed your research teams in relation to the topic and the methods you described.
Research teams, you said? So our teams, we had myself. I am a leadership educator at the university where I have worked. Again, very interested in the leadership part. My other team member who has been with me since the beginning of the education part is Dr. Varpio. And she became interested in the topic and was really helpful in kind of thinking bigger thoughts around what this means and how do we really think about this from a qualitative perspective. Dr. Tennyson was a provider that was able to bring that clinical perspective to our team. And then we were able to, in different settings and different papers, add in additional members. So we brought in a couple members that are in the military to provide that military perspective, to make sure that we weren't saying anything incorrect with the military part of it, but also provide information around those teams and what was happening, but also, they also have clinical experience. So being able to have that dual hat on the different teams. So that was a brief overview of the different members of the team and how they brought different perspectives to each of our studies. And we would debate that in many meetings.
So in terms of how you set up your team for this project, as we get ready to launch you into the world as a scholar, how do you think you're going to design your research teams going forward? And what are some of the things that you think are critical to have on a research team?
Great question. For myself, I think a lot of it comes back to the emotional intelligence. I think having the awareness of what you know, to be able to know this is what I can provide to a team, but also understanding that I have my own gaps and that this has opened up a whole lot of new ideas and places that the research can go, but knowing that I don't know everything and I don't know how to do everything. So knowing and being able to ask other people and know what their expertise are. So again, knowing yourself, knowing the roles of others, so that you can understand from that team kind of what we're working towards. I think, again, yeah, knowing your limitations, but as you start those teams, finding people that you can work with and having those open conversations with each other has been very important. I've worked on great teams. I've worked on very bad teams. And having that communication that we know what we're working towards, having very clear boundaries of who's going to do what has been very helpful in the teams that work well. When they aren't working well, you can definitely see where those breakdowns happen, and a lot of them are around communication, nobody knowing who's supposed to be doing what. And so I think there's a lot of, again, clarity around roles. A lot of the themes that were brought up within the articles really put into play for research teams as well. What are we working towards? Having that open communication, knowing that you have to be flexible because funding is always an issue, or being able to, someone moves and we can't be part of the team, or we have limited resources, being flexible, but also being willing to have psychological safety on the teams, that people want to work together, that it's a safe team for people to learn and fill their own gaps of knowledge and be able to keep moving forward in the field, but also in their own education and learning.
Just to tie it back to your topic, how do you identify the leaders and the followers within your research team?
I have to interrupt. We have to move on to the next opponent. Excuse me. Thank you, Professor Maggio. The next opponent is Professor Jascha de Nooijer. She is Professor of Interprofessional Teaching and Learning at Maastricht University. And she is also Secretary of this committee. Professor de Nooijer.
Thank you, Pro-Rector. Dear candidate, I would also like to compliment you and your supervisory team with this great achievement. It was very well written and nice to read. You probably know that I'm interested in interprofessional collaboration and interprofessional education. And for me, the constructs of leadership and followership were quite new. But I wonder if we are really on the same page. So I would like to discuss a few things with you. Can you maybe first explain the photo on the cover of your thesis for me? Who's the leader and who's the follower?
Great question. Thank you, esteemed professor. It was interesting when you're asked, what are you putting on the cover? It was a hard decision to figure out what do you want to put on there. And I think in my mind, we are both a leader and a follower in many situations. So trying to think about, there are times we are going to follow, there are times we're going to lead. So it really stuck out that I was able to help create an image to think about, you know, we have two different faces. We can be the leader, we can be the follower, but we still have ourselves within us, and we have to know ourselves to know when we need to step in and lead, but also knowing when we should also step back and follow.
Okay. Then we go back to some other questions. While reading your work, I was wondering how helpful you think it is to distinguish between this concept of leadership and followership, especially in interprofessional teams where you just mentioned it also in your presentation, you have a shared mission. And there is this fluidity in the team that you can easily switch between roles. So can you elaborate a little bit on that?
I think the term leader is used, it's been used for centuries. So it's been the term that I think has been used. The term follower it's coming up more and more. And I think a lot of what we teach at Uniformed Services University is that we are both, again, leader and a follower, and knowing when to step in is the important part of it. So knowing that you might not be the titled leader, you might not have that positional role as the leader, you might not be the physician in charge of the team, but your role is very important as well. So knowing that you are accountable and you are reliable on that team and you are able to step in, and not everyone can do every single thing. So knowing that you are leading in that space where you are the expert in that very small, or the very small, big, whatever is going on in the setting of trying to figure out who can do what. Because if a code is called, or we even talk to our students that in an anatomy lab, there might be an assigned leader for the team, but it might switch roles depending on if someone else had studied something else or they had had experience somewhere else, they might take over and be able to lead. So I think we think of leadership as very positional, and I think that came up very clearly when we looked at the attending physician's perspective, that they were very thinking about leadership in a very positional way and not in the fluidity way where you can move between different roles depending on what's needed at the time, where you are in the process. And so being able to really have the kind of be aware that you're not always leading in different situations. And I think that that's been interesting to watch our students try to comprehend, and again, healthcare providers as well. It's been a very interesting conversation with them about that.
But from the perspective that you have a shared mission or a goal, wouldn't it be more helpful to just delete those terms, leadership and followership, and see their equal contribution, or equal depending on the topic, of course, but contribution to the shared goal?
I think that's a great question. And I think the military starts really, especially in deployed settings, they kind of have that start to happen, that the roles, if you pull rank, it's not seen as going to go well. You can't do this because I said so, because I'm the leader and because I outrank you. It does still happen, and there's times that should be done. But I think if we do erase those words, there could be more collaboration, because there's more shared accountability behind what we're working towards, whether it's this surgery, whether it's this presentation. We can have more ideas, and maybe people would be more willing to contribute to those teams and see the value of where they're falling into the team.
Well, moving to those military context, I think hierarchy is there very evident, maybe even more than in healthcare teams. Could that context in which you did your fieldwork also be an explanation for the findings that interprofessional sharing of leadership was harder than intra-professional leadership?
So we were talking about this at a conference a couple weeks ago, that within the military, the hierarchy exists, and that's how they function, that's how everything moves forward within the military. But a lot of our members of the team that we put together, a lot of the people we've talked to within the military, they were very specific that yes, there's rank, but in many cases, the nurse might outrank the surgeon. And that does not mean that the nurse is going to be the leader of the team for every single aspect, but there may be points where the nurse is going to take over and be the leader. And so I think it was very interesting to watch how the hierarchy played out, and that the military members felt that it was not a barrier to having effective teams. And when we talked to members that are not in the military, they much more mentioned the hierarchy, that it was very ingrained in it, that if I'm a resident here, I'm going to have more trouble stepping up and saying something, because if my attending doesn't like me, I can be fired. Mm-hmm. And so while that can still happen within the military setting, it wasn't as prominent as it was in the non-military members of the team. They were much more, there seemed that they could be much more fluid, but they were still positionally focused on that term leader versus being able to know that they can move between different roles.
Okay, that surprises me. I would like to continue with a question about chapter 5 and 6, and especially about the sample you selected there. How did you ensure that the sampling method was representative and diverse enough to understand the qualities of leadership and followership in those teams? And are all those professionals that were included working in teams? Because I wonder if, for example, a dentist is always working in a team and could therefore discuss these concepts as leadership and followership as well.
Great question. For both of those chapters, there were 30 participants that range from a medic up to Surgeon General, so from the lowest person on the team up through one of the highest. And so it really, all of them, they were not allowed to be in the study if they did not work on teams. So that was one of the inclusion criteria for those studies. And but in many cases, like you say, a dentist is not always working in a team, but they probably have different techs that they work with, and within the office themselves, they'd have people at the front desk, they have people helping with cleaning supplies. So it kind of has to broaden out beyond just maybe that office, that there's a bigger picture for what that team is. Being able to call down and say, my tools aren't clean. If you can do that in a nice manner, you might get them faster. But recognizing in those settings that communication, I think, is one of the biggest parts. So I think it's very important for people to, I guess, see themselves beyond just themselves. I think a lot of times, especially if you have that titled position of leader, not using that to stand up and do this because I'm the leader, but being able to recognize that other people might have expertise, and you're going to need those other people to achieve that goal and mission that you might be working towards.
Okay. Thank you for your answers. Thank you, Pro-Rector.
Thank you, Professor de Nooijer. The opposition will be continued by Dr. René Stalmeyer. She is Associate Professor of Medical Education in the School of Health Professions Education at Maastricht University. Dr. Stalmeyer.
Thank you, Pro-Rector. Dear candidates, I join my colleagues present here today in congratulating you and your team with this important work. I'm sad I cannot be there in person. Apparently, I had tickets to flu season that they forgot to inform me about. The quality of your work speaks from the fact that all your studies are published. They contributed to increasing methodological understanding in the field. And the impact of your work is already visible in the curricula in which you teach. The way you are making a meaningful impact on the field and on our future healthcare professionals is impressive. Congratulations. I read your thesis with great interest, since over the last couple of years, I've been exploring various dimensions to the conundrum of how best to foster collaboration-ready and collaboration-willing healthcare professionals, and which mechanisms and barriers are at play. And from this research, there are several barriers and mechanisms that are recognized in your work as well that I would like to reflect upon with you. So the two recurring themes, and we've been talking about that already in this defense, that jumped out at me are the being deployment ready and the having a shared understanding of the mission. And although these are very much military concepts and part of a shared and embodied culture, I can see the potential for conceptual translation of these concepts to civilian healthcare practices. However, I have two questions. When would you situate this concept of being deployment ready within the learning trajectory of civilian healthcare professionals? I'm asking this because the issue of timing of interprofessional education has caused quite some debates in the fields. And we are still not clear on what might be the optimal timing of interprofessional education and at what point we can expect our trainees to be deployment ready. So when would you situate interprofessional education, and when do you situate this deployment ready competence?
I think this is a great question, because I agree with you that it is very controversial as to when these topics should be discussed, and how do we get people to recognize when they need to focus on their own education as well. Because I would argue sometimes that we struggle with our medical students in that they're not ready to talk about leadership and followership because they're so focused on, I need to understand the medicine before I can think about the people part of it. And it'll be fun when they come back after clerkships and they're like, you should really talk to us about emotional intelligence. And we're like, we did. So I feel like it's an ongoing process. It's something that can start much younger than medical school. It could start in college. It can start, I say it happens in our house a lot of times. We have many conversations around these topics. And so I don't know if there's a great answer for that at this point, because I think that it's so controversial and not everyone has the ideas and concepts to be able to really think when we should be thinking about these different things. Because I think it has to be taught from an early age. If we teach them, how do we work in teams together from an early age, maybe that's going to make it better on the backside. When we need them to be functioning in highly functioning teams and high fidelity teams as well. So I think that there's a lot of debate, and I think that'd be a great I don't even know how we can figure out when that timing would be. But I do think it should start early.
So I've heard you say emotional intelligence a couple of times, and I have to admit that's not a concept I've worked with before. I did a very quick Google search while I was listening to you, and I see that it's consisting of different dimensions. And I just also heard you say maybe we need to start with this very early, even before they come to medical school. So if you would kind of dissect deployment readiness through the lens of emotional intelligence, which ones of those dimensions would you introduce when, and which ones will not start to make sense until they hit actual clinical practice?
That's a great question. So I think it's going to start with self-awareness. Are you aware of what you're able to do and what you're not able to do, and having that humility to know what you don't know, to be able to know, do I need to get some education in this? Do I need to talk to some other people? Do I need coaching, different education or training? So I think it's going to start with self. I think a lot of the teaming part of it really is going to start with self. And then I think the social awareness is also going to be a big part of it, because we have to then be aware of other people on that team. And how can we know where their limitations and strengths might lie as well? And if we can recognize that, we might be able to help fill gaps, or especially if you're in a leadership position, recognize when we might have an opportunity to allow people to go off and do additional training, or to be able to know, hey, you might be really great for this opportunity, and be able to sponsor them in different situations. So I think social awareness and self-awareness are going to be the top two ones I would say are the most important within that deployment readiness, within readiness in general for most of our physicians. The management part on both the self and the relationship is going to come next. I think if we don't know ourselves, we can't really understand that we're able to manage our own behaviors or help manage other people's behaviors.
Right. Okay, lots more to go into that, but there's other questions I would like to ask too. So we have been talking about the mission quite a bit. And what actually stood out for me, which I haven't heard you reflect about, is the urgency of that mission. And we know from the literature on leadership and followership that as soon as there's high acuity care, it's not as big a conflict. It's when you get into chronic care, primary health care, where people do, especially with comorbidities, need all kinds of inputs, but that their leadership and followership actually becomes much more complicated. And I would say that the majority of care provided is within that primary healthcare and in chronic care. So how, within that situation, can we instill a sense of urgency? We're not going to threaten to bomb the hospital. So what is it that you think we can do? Because the urgency of patient-centered care is clearly not enough.
I think that is fantastic because I completely agree with you. And I think in the military settings and a lot of their stories did come from those immediate, we have to do this now. This is the only thing, you know, we have patients coming in off a helicopter. And so I think that's where the breakdown kind of occurred, but more in the standard hospital setting, that they're only looking at that title of leadership and not seeing the urgency. And I think there has to be a change in how we really see ourselves as part of that team and that patient care ownership, so that it's not just about me being able to provide the answer to a patient, but recognizing that there's more members of the team. And especially when you start looking at complex care, how can we know that we need to communicate with each other? Why are we sitting in 4 different teams to tell a patient what's going on without communicating with each other? And I think that would be a great start within hospitals. How do we have that more intra and inter communication happening?
I'm looking at the prorector. I think my time is up. Am I correct?
Your time is up.
Thank you. Thank you, prorector. Thank you, dear candidate.
Thank you, Dr. Stalmeyer. The fifth and last opponent is Dr. Juliette Beuken. She is assistant professor at the School of Health Professions Education at Maastricht University. Dr. Beuken.
Thank you, Pro-Rector. Dear candidates, in research we always share something of ourselves, and it is both good reflexivity as well as a gesture of love how you gave insight into your own story. My compliments to you and your team. I'm very happy to be one of the members of the opposition and get the opportunity to share a little bit of leadership to make these last minutes of your defense count. So let's get to that. And I want to start by asking one of your paronyms to read proposition number 10.
Setting an example is not the main means of influencing others. It is the only means. Albert Einstein.
As a non-clinical educator, what does this proposition mean for what I can do? Am I sidelined by Albert Einstein, or do you see a way for me to still contribute to these important developments, given that I cannot role model in the practice of healthcare providers?
Thank you. Great question. I also am not a provider, so I think that speaks well to me. And I think that that's something that has come up in many situations, and that building that credibility with the teams and discussions with people, especially as we teach leadership and teach followership, how can we bring that out? Because I think all members of the team, we can all contribute to something, and recognizing that and having the humility, again, from all perspectives, everyone has to have the humility of what we know and don't know, and that other members of a team that may not have the same shared experiences on different things can really still provide insights and learnings for all of us.
Okay. Thank you. I feel valued. Another question that I want to ask you is about your discussion. Here you talk about the role of hierarchical structures. I practiced pronouncing this. Hierarchical structures that are built into the cores of professional identities and that don't always benefit healthcare. On page 114 of your thesis, you propose that we should overcome hierarchical barriers and facilitate egalitarian structures. I would like to use a different phrasing and say that some structures might need to be broken down. And I doubt that traditional leaders and followers are able to do this, to pave the way to the active followership and the shared leadership that you describe. So forgive me the arrogance of introducing a new concept, disruptorship. Disruptors are those breaking down harmful hierarchical structures to improve care. And I'm curious to hear your thoughts on this new concept. Do you agree with my ideas, and how does that resonate with your findings?
I do agree with you, because I think I say it clearly is not working well right now. And I think there's lots of issues within healthcare that we see no matter where you are in the world. And we do need disruptors to challenge what's been happening. That's the only way the fields will move forward. So yes, 100% we need disruptors, and finding those people that are willing to stand up and be active followers in that setting. They're going to lead eventually, but they're right now a follower. So how can we step up and say, in this moment, you know, I am following, or I am behind this person, I'm following this person, but I might disagree with them. And so being able to challenge the hierarchy is going to be important to make change, because without them, we're not going to evolve.
Mm-hmm. And you see that as a part of active followership, if I understand correctly.
Yes.
Mm-hmm. And have you seen acts of disruption in your research?
I would say yes, and especially within education, Ira Chaleff talks about it being courageous followership, so that you have to stand up against the hierarchy, as I think even one of the 7 items that he lists. And so being able to really challenge people, especially in times where you're able to be challenged. There are times that we cannot challenge the leader, and we need to know that this is where we're working and we need to get this done immediately. But knowing that there are times that we can challenge and debate back and forth what would be best, and focus on the task conflicts that we're going to have versus, you know, don't make them into relationship conflicts. How can we really continue moving the field forward and be able to, again, move the field forward? We're not going to be able to do that without these disruptors and being active and not just passively sitting by and letting people, oh, someone else will take care of that.
Mm-hmm. Yeah, I have a bit of trouble with the idea that it cannot be a relational conflict, because hierarchy is about relationships. Mm-hmm. Can we disrupt the system? Can we break down structures of hierarchy without these relationship conflicts?
I would say yes. I think the literature within relationship conflicts is more about butting heads because I don't like you. And so if we can focus on building relationships and being good humans and having that awareness of others and what's going on with other people and the conversations we have, I think we can break down different hierarchies and recognize that all members of the team are valuable and are bringing something to the table.
Yeah. Just to pick your brain a bit further, how would you maybe investigate these elements of disruptorship or courageous followership as you name it?
Great question. I think there's a lot of great qualitative studies. I think that getting people, finding out different people that have put forward different policies. I think policy would be a great way to kind of start thinking about that, because they have made the change. So how did they do that? And asking questions around that of, how did you do this? What were the barriers? How did you feel? Because that's got to be a scary place, I think, that you have to have moral courage for, to really step in and say, this isn't working, and I think I can try to find a better way forward. Probably not alone. It's going to take a lot of people, and you're going to need that first follower to kind of come with you, and you become that leader. So thinking through how can we do that? But I think a great qualitative study going forward.
Yeah, I think it falls a bit into the discomfort of some of these interactions, right?
Yes.
I have one final question that I would really like to ask you. You start beautifully with reflecting on the healthcare team that took care of your dad and how that really sparked this idea of followership and leadership. Let's imagine that the team that took care of your dad was here today. Mm-hmm. What would you like to say to them? What would you advise them?
Great question. I think it's going to start with we're all working towards the same outcome of patient care. We want the patient to, they can't always be happy and healthy, but we want them to feel that they're part of that team and that they are part of this process as well. And we don't want them to leave discouraged and distrusting of the system itself. So if we can communicate better, if we could have had a pre-meeting of all of, let's get all of the tests run and let's discuss what does this mean in this interprofessional but intraprofessional with the different physicians, what is the next step? I think we could have more ideas and be more innovative if we are able to.
Mrs. Berry, as you have noticed, the time for defending your thesis has passed. The committee will now withdraw to discuss the quality of your thesis, in particular the quality of your defense, and please await our return here.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side. 7 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. On the line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future than we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror, I know what it felt like. My goals only getting clearer, east side to the west side. No place like home, if there's questions that you've got, go the extra mile and die. can't read your mind. Years can't fly by now, don't waste all your time. 'Cause I'll go the extra mile.
Here we go.
Mrs. Erin Berry. The degree committee here present, and not only here but also online, has assessed the quality of your thesis and also the quality of your defense. And in view of this positive verdict, and taking into account, of course, your previous qualifications, the degree committee has decided to grant you the degree of doctor. And Professor Teunissen is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite your supervisor now to take the floor. Professor Teunissen.
So before I can actually give you your certificate, there are a couple of things we need to check here. The first is a promise. Do you promise to work in accordance with the principles of scientific integrity at all times? To be careful and honest, transparent, independent, and responsible?
Yes, I promise.
Great. Then, by the authority vested in us by law, and in conformity with the decision of the committee here present, I hereby confer upon you, Erin Berry, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university.
Hand it over to you for the picture. Congratulations. I'll put it here so that it won't. Yeah, if it falls, then that can break.
And then Lara Varpio will give her laudatio on behalf of the two of us. So Lara, you may speak.
Thank you. Thank you, Pim. Dr. Berry, Erin, I have a great honor of congratulating you today on completing your doctoral degree, and I get to be the first to take a few minutes to congratulate you and celebrate you on this significant accomplishment. I still remember back to 2018, in the first days of your graduate training, and I doubt either of us could have predicted the journey that lay ahead of you. You moved across state lines more than once. You changed graduate programs. We faced the pandemic. There were personal losses. There were joys. There were new jobs. There was so much that we could never have predicted, Erin, on the day you and I first started talking about your degree. But I always knew you were going to finish because, Erin, you are one of the most you have the perseverance that is quite honestly unmatched. And in retrospect, I'm really glad you moved your degree to Maastricht. Having Pin on the team helped us to bring new insights and new perspectives to your research on leadership and followership in healthcare teams. I know I speak for Pim when I say that working with you has just been a joy. You conducted thought-provoking literature review that made the pages of BMJ Leadership. You literally wrote the manual on how to conduct a state-of-the-art review that is now being cited regularly well outside our field. So for instance, in preparation for today, I did a little research and I can congratulate you on being a cited expert in sustainable transportation research and also in aluminum metal matrix composites. Erin, well done. Then we have your evidence papers in academic medicine, a top-tier journal in our field, and in military medicine, a journal that speaks directly back to the audiences that you studied and that you serve as a professor now. The fact that you accomplished all of this in just 6 years, part-time, with COVID, and during all of the events that happened, well, Erin, that's just quite impressive. Something that's only someone with the deepest of passions, the most determined mindset, and the most diligent practices could have accomplished. And that's who you are. Another thing that Pim and I both noticed, and something that truly sets you apart, is your ability to not only listen to feedback, but to embrace it and take it on and learn from it. Someone once said that feedback is the breakfast of champions. You demonstrated awareness of that over and over again. And I know sometimes it was a lot, but you unwaveringly embraced it and acted upon it and came back to us with new versions of coding or analysis or papers that were even better than the first. Erin, your attitude towards feedback is something that's going to set you apart in the future. I want to congratulate you on that because it has made your career and your thesis really strong. I'm also really glad that your family is there today. It is so important for them to see you on this stage and at this event. So often our children don't know just what we do outside of the very important world of theirs, their very pressing circle of needs and their immediate life. Today, they see you achieving a very important professional milestone. I'm so glad that they can witness you achieving this accomplishment and hear from important scholars from around the world that you exceeded expectations. So one day, Erin, a learner will come to you and say that they are interested in doing a PhD and they're going to look to you for guidance. And I would like to suggest to you that you look for some of the same things that I looked for on the day we met. Does this person have the passion to pull this degree off? Yes. Does the person have the intellectual capacity to do this? Yes. Does she have the tenacity to finish? Yes. And then I hope you are as blessed as I was to be able to start working with someone who has a deep understanding and a deep appreciation for the work, who also upon occasion will give you back the gift of time, who will unfailingly take feedback with a growth mindset and unwaveringly do whatever it takes to meet our goals. So thank you, Erin, for letting Pim and I be part of this journey with you. And congratulations on your success. We are both very excited to see what comes next for Dr. Barry.
Esteemed Dr. Barry, dear Erin, it's my great pleasure to congratulate you with your doctorate, and I do that also on behalf of Maastricht University. And I would also like to share some impressions of the committee with you. We have seen a very well prepared and very clear summary of your thesis to start with. And your thesis is of high quality, well written, and you showed your engagement with the topic. And we can also see that a lot of work has been included to get this result in the form of your thesis. And also we have seen that I think that almost, if not all of your papers have been published in scientific literature. And I think that, and the committee thinks, that your work has really impact for the practice of healthcare in the future. In your defense, we had quite a variety of questions, and your defense was appropriate and adequate. So we appreciated that. And also we've seen that, again, you showed that you are very passionate on your subject, open for feedback, and that you have scientific expertise on the subject. So I congratulate not only you with that, but also your two supervisors, Professor Pim Teunissen and Professor Lara Varpio. Congratulations with the result that we have seen in the form of thesis, published papers, and an excellent defense. I would like to include in my congratulations also your near family, your husband, your children, and your mother, and other members of the family, I think, here on the first and the second row. So congratulations with this result. I would like to thank all the members of both committees, the Thesis Assessment Committee and of this Degree Committee, for critically reading the manuscript. And I would also like to thank you, the opponents, for interesting questions and to be able to have here in public to see your defense and your passionateness with the subject that you have studied during the past years. And I would like to thank in particular the external members of the committee. Maastricht University appreciates your contribution, so thank you very much. Before I close this academic ceremony, I would like to invite the 3 online members of the committee to congratulate you. And I would like to start first to Professor Lauren Maggio to start. May I invite you?
Congratulations, Dr. Berry. I've had the privilege of knowing you, I think, over the last 7 years. And like Dr. Varpio, as you've moved through the scholarly community, you really have found your place. And I'm so excited that you're going to be a member of our community. And I look forward to your future scholarship.
Thank you very much. May I invite you, Dr. Stalmeyer, René?
Congratulations, Erin. It's so nice to see you now, where I also saw you in the PhD writing course. And we had the first discussions about the development of your research project in the middle of COVID. And it's gratifying to see how well you've done and how much you've accomplished. So congratulations. I hope you have a big celebration plans, and it's nice to hear that you have a lot of family members and friends with you to celebrate with you. So congratulations.
Thank you all. Before I close the ceremony, I would like to advise you to stay here after the ceremony, to stay here. We may make a picture of the committee and also with the external members and the members online on the screen. And then we will make a second picture in the hall on the stairs. And I invite you all to go to, not all, because not all of you is able to go there, but we have a reception in the rafter. Hereby I close this academic ceremony.